Yeah.
Good morning. Welcome. Thank you, everyone, for coming to Primary Children's Pediatric Grand Rounds, everybody at Lehigh Hospital as well and online. I'm Miguel Canacal, one of your pediatric hospitalists and the course director. Today is the lecture presented by Family Medicine and Public Health, Sarah Hawley, visiting professor. Today's Cloud CME claim credit code is 52528. 52528 for everybody to claim. The text way is the easiest. If it doesn't work for you, come to me afterwards. I'll show you how to do it. And the online questions go in the live chat. Oh, was I just not holding it close? Oh, ooh. The online questions go in the live chat, and for those in the auditorium, just raise your hand, and if there is question time at the end, the speaker can just call on you. Okay. Do you teach any CME lectures, or if you're a doctor, do you teach any CME lectures, or a physician who's going to give a talk for medical students or residents? If so, you can claim this Learning from Teaching. You just go to that Intermountain Cloud CME website, click on Learning from Teaching, and I simplified it drastically. It's the easiest thing in the world. Do a little reflection on what you learned by preparing from teaching, and you get 4 times credit. So like if you teach a 1-hour lecture to the residents, you just go and claim that really quick. You sign into the cloud and claim it, and it's 4 times CME credit. And it helps us see how much amazing teaching we're doing. Please nominate a safety hero when you see someone use an error prevention technique. This one I'm going to tell you about is a music therapist who was in our Sophie's Place studio when a teenage patient and his mother came into the room. The mother shared that the patient was supposed to be in the procedure center, but he wandered out because he was hungry, was NPO so long and agitated. So the mother tried to redirect the patient, but it ended up getting him shepherded into Sophie's Place, where he was a little bit more contained, and the immediately began picking up musical instruments and playing them. So then the music therapist just calmly kept him distracted and with the music, and called the procedure center, said that he's okay, he's not missing, and security as well, but also requested the security kind of keep the distance to not trigger the patient, and then security said, okay, we'll just stand by. And she stayed with the patient until he was ready to leave and walked him down to the procedure and played music with him all the way down until he was under anesthesia. Yeah. So I think it's just really sweet how we do that here and keep people safe and really in a customized way. Okay, so I'm going to switch to this here. Okay, so Dr. Susan Kokella in Family Medicine wishes that she could join us to introduce this year's lecture herself, but she was unable to remove herself from clinical duty. She's out there stamping out disease and preventing disease and promoting wellness right now. So I'll share a few words from her. She wanted me to share she and the Family Medicine program greatly appreciate the collaboration around our shared interests. The Sarah Hawley Memorial Lecture is an annual lecture in the Department of Family Medicine Public Health that celebrates a gifted and compassionate family medicine resident, Dr. Sarah Hawley. Dr. Hawley's 3 passions of women's health, children's health, and the connection of health, human health to the great outdoors are the focus of the annual lectureship in family medicine. So every 3rd year, when the lectureship focuses on children's health, family medicine and pediatric grand rounds work together and invite a collaborative presenter to speak to both audiences. And this year's speaker, Dr. Erin Brackbill, is Clinical Associate Professor of Pediatrics at the University of South Carolina and Prisma Health Children's Hospital. She's a national expert on approaches to pediatric obesity for families impacted by the social drivers of health. She's a fellow of the American Academy of Pediatrics, co-chair of the South Carolina chapter of the AAP's Healthy Lifestyles Committee, and diplomat of the American Board of Lifestyle Medicine. And she was also awarded fellow of the American College of Lifestyle Medicine and an officer for their Pediatric and Adolescent Medicine Interest Group. And Dr. Brackbill's favorite professional role is being faculty in the Pediatric Resident Continuity Clinic. She enjoys bringing this lifestyle medicine with health equity focus to the residency program. And speaking of lifestyle, Dr. Brackbill and her husband met at Davidson College, and their parents to 2 college students. Erin loves all the outdoors activity, reading, playing games, and I have a fun social connection for you as well, local connection. So while at UNC School of Medicine, she ran the Boston Marathon with one of her best friends, anatomy lab partner and roommate, primary children's own Dr. Maya Holste. And so she's beloved with that connection as well. Yesterday, Dr. Brackbill delivered the family medicine grand rounds entitled Meeting Families Where They Are, an Equity-Driven Lifestyle Framework to Address Childhood Obesity. And today she presents for us at Primary Children's Hospital grand rounds on pediatric lifestyle medicine. And really, she's been talking with us for a while, really customized this up for us. So I really appreciate her expertise so much. Thanks for teaching us today.
Thank you so much for that kind introduction. It really is an honor to be here with y'all. Thank you for the in-person and online attendance, but it's just nice to see faces today. And I know that Grand Rounds tends to get smaller these days with online, so I appreciate y'all being here in person too. As I was preparing this, I was imagining how health professionals who would choose to be in such a gorgeous outdoor mecca would already be bought into lifestyle, right? Especially probably around physical activity and time in nature. But with non communicable chronic diseases being the top cause of death in adults, and the rates of obesity rising and cardiometabolic risk factors increasing in children, we really need to ask, how can we be best equipped to stand on that front line for change, both in our clinics and in our communities? And lifestyle medicine is one way that you can improve or enhance what you're already doing as pediatricians. And so I'm wanting to share that with you today. I don't have any disclosures. So today, I'm going to just define the specialty of lifestyle medicine so that you're familiar with that. And we'll talk about the 6 evidence-based pillars or interventions for lifestyle medicine and how they can work together to address chronic disease in children. The way I initially got interested in lifestyle medicine is just seeing more children with obesity. So, in the time since I graduated from medical school, the rates had increased about by 50%, I think, since I finished medical school. And I just wanted to do a better job with my patients, even though I went to 2 great programs for medical school and residency. It wasn't standard to train with a robust nutrition education. We didn't do a lot around behavioral change counseling and prescribing lifestyle, and I just wanted to learn more. And we happened to have a family medicine resident came and rotated through our clinic, and I noticed she knew a lot about this. So I was like, "How did you learn all of this?" So she told me she went to medical school where I work, so at the School of Medicine, Greenville, and they're one of the first in the country to incorporate lifestyle medicine across all 4 years of their curriculum. And in addition, in her family practice residency, she was pursuing that certification as well. So then I took her out to lunch to learn about it, and I got certified in it. So that's how I got interested initially. So I'm going to review just the basics about lifestyle medicine. So it's a specialty that uses 6 evidence-based therapeutic lifestyle interventions to prevent, manage, and treat chronic disease. So whole food plant-based nutrition, regular physical activity, restorative sleep, social connection, stress management, and avoiding risky substances, or in pediatrics, we sometimes say avoiding risky behaviors with the younger kids, so we could include screen time. The training has robust training in motivational interviewing, positive psychology, and prescribing of lifestyle habits. It's very patient and family centered. It's culturally responsive. One of my favorite things is there are members and diplomats from across the world. And so you just get that wide cultural perspective. And for those who practice with patients who are most impacted by social determinants of health, there's a health equity initiative in lifestyle medicine emphasizing that all 6 of these pillars are strongly impacted by the social drivers of health and health inequities. And that is my focus within lifestyle medicine. So just so you know my setting, I work in the resident continuity clinic, and we serve the largest number of children with Medicaid in the state of South Carolina. We also do a lot of immigrant health and immigrant health for kids with special needs. The AAP past chair of the Council on Immigrant Health is one of my partners, and she brought the National Youth Advocacy Program to our clinic. So we see unaccompanied minors who have across the border and need intake for physical and mental health needs. So you can tell through that we see patients with a lot of need. So my focus always within lifestyle medicine has been that lens. Oh, what did I do, you guys? Okay, so I wanted to then show you there is a variety of ways people can use this within pediatrics. So the Tiny Beat and Honeybee are two examples of people I know through lifestyle medicine. Those are like direct patient care, private practices that revolve around healthy lifestyles. And that's why the families are choosing those practices. So they are lifestyle medicine practices. Um, there are pediatric cardiologists using this, endocrinologists, surgery offices, um, oncology offices. And also, if you see the one that says Rika Salute or Rich Health, that's the program where I work, and we use lifestyle medicine around a comprehensive approach to childhood obesity. So the Dr. Yum Project is something I'll talk about in a little bit. That's a community focus on preschool children, and then there's also uh, teen programs for lifestyle medicine out there. I think I'm just going to use the arrow. So one of my favorite parts, besides the international aspect of lifestyle medicine, is this collaboration across the lifespan to improve our health span. So instead of working in our silos, like what I've learned about prescribing exercise, some of that's been from expert exercise physiologists and exercise therapists, and learning nutrition from dietitians or other folks that have expertise in that area. And I'm working right now on a 0 to 5 year old healthy lifestyles toolkit for ACLM, and we pulled in the women's health group, so the OBGYNs, to help us write the prenatal part of that toolkit so it's more comprehensive. So it's really a way that we can collaborate and work together, where the ultimate goal is that patients would start to hear the same evidence-based messages no matter where they enter the health system and no matter what age they are, and then also out in their community. And in our system, you're starting to see that. So the adult cancer center uses lifestyle medicine, pediatrics does, family practice, internal medicine, and then the medical school. So it's just families are starting to see the same message wherever they go. So ACLM, which is the American College of Lifestyle Medicine, they are one of the leaders in building capacity to address chronic disease across the country. So there are programs in medical schools, health professional programs, so it's not just for doctors, as I mentioned before, residency programs, as well as undergraduate programs for people that are interested in learning more about this. We, as you know, as pediatricians, are seeing more chronic disease than ever before. So the prevalence of pediatric chronic disease has risen to nearly 30% in the past 20 years. 25 million 5 to 25-year-olds are living with chronic disease, and the top chronic diseases, asthma, ADHD, and obesity at 21%. And if you look at the most recent statistics for obesity and overweight combined, it's like 36% of children. And I heard a quote recently that I liked that said that awareness can breed despair, but action can bring hope. And in talking about these lifestyle medicine pillars, I hope that you'll see some like ideas or actionable steps that'll enhance what you're already doing. So we'll go through all 6 of the pillars. There's a few extra slides around nutrition than the other ones. But what lifestyle medicine recommends is a whole food, plant predominant diet. Bless you. So um, basically, increasing whole foods as found in nature, the fruits, vegetables, legumes, whole grains, nuts, seeds, herbs, spices, and trying to minimize the things we know to minimize. So the added salts and sugars and ultra processed foods and fried foods, and also being cautious about processed meats and red meats. And we'll talk a little bit about that in a minute. But the idea is not perfection, it's progress. So it's moving from the standard American diet to a healthier, whole food, plant based way of eating. So this graphic is looking at those healthy eating index scores. How are children doing compared to the dietary guidelines for Americans? And as for the whole lifespan, I think the top score, the average score, I'm sorry, is 58%. If you look at children, the best we're doing in the youngest kids is 61, and that's 61 out of 100. And the scores get worse as children get older. The scores are worse if you're more impacted by the social drivers of health. And mostly the lower scores are related to a lack of fiber rich, nutrient dense plant foods. So 95% of us are deficient in fiber. So this graph, which you all may have seen before, is looking at the individual dietary components, and the line across the center is like the limit or the goal. And the biggest thing I wanted to point out here today is these fiber rich, nutrient dense foods like the fruits, the vegetables, the legumes, the whole grains are what we are clearly deficient in. If you look at protein, we are doing fine with protein. If you look at social media, everybody thinks we're deficient in protein, but good evidence supports that most Americans are not having trouble with protein. We are really having a crisis of fiber. So as pediatricians, like we are preventionists by nature. You know a lot about nutrition and prevention, especially talking about weight management, metabolic health, cardiovascular disease. A couple of things I just wanted to highlight that I find interesting in the literature and I'm kind of following. Um, First of all, I guess with cardiovascular disease, I wanted to mention that older autopsy studies looking at the vasculature of children, even the older studies would show fatty streaks as early as 3 years old. And almost all children had fatty streaks by 10, and by 20 years old, they were already in the coronary arteries. And these were older studies when eating habits used to be healthier. And exercise was more abundant, right? People were more physically active. So I can't even imagine where that is today. And it just emphasizes how important it is for us as pediatricians to prevent these cardiovascular risk factors. So I'm interested in what I'm seeing around cognitive function for nutrition. So the MIND diet is a whole food plant-based diet. It's kind of a combination of DASH and Mediterranean because you probably are familiar with those terms. And it people who consistently follow a MIND diet had like 40% decreased risk of Alzheimer's. And in children, there was a Finnish study that was in last month's Journal of Pediatrics, and it followed children for 20 years. And over those 20 years, they found that for children with adverse lipid profiles and elevated BMI, they had lower cognitive performance and lower cognitive flexibility as young adults. So these are all early these are early studies that are just like calling for more research in this area, but it's just something interesting to follow that has to do with healthy endothelial function in the brain as well as the rest of your body, right? Certain whole food plant-based nutrition is correlated with a lower risk of certain types of cancer. Unhealthy diet is linked to 38% of colorectal cancer. And there was a 2025 Global Cancer Research Update meta-analysis, and it confirmed that not only is early onset colorectal cancer increasing by up to 90%, they said, by the year 2030, but it's causally linked with elevated BMI in childhood. So the two factors that they highlighted were frequent fast food and a high fat diet. And this early onset is like 20 to 35-year-olds. So I've read articles in various, pediatric journals calling pediatricians to prevent colon cancer. And who thought when we started our training that we would be thinking in those terms, right? But it is so important what we're doing when we counsel lifestyle. Um, Unhealthy diet is also linked to liver cancer, pancreatic cancer, postmenopausal breast cancer, mouth, esophageal, and throat cancer. And it's estimated that it's more important what a woman ate in childhood than in the 10 years before she was diagnosed with breast cancer. That's how important eating habits are. So some nutrition strategies in clinic, and I'm very conscious that you guys are like a center of excellence. You all know about healthy lifestyles through AAP and the other things that you learn about. So I'm trying to think of things that helped me that were outside of what I learned from like the AAP, right? So, of course, we want to do trauma informed food security. Do you have enough food? And nutrition security. Is it nutritious and like adequate food to for your growth and development? This kind of screening and education, if you don't already do it, I just wanted to point out Leah's Pantry, which is out in California, and they are a national leader in training around trauma informed nutrition screening and education. So, we want to talk in clinic about addressing the fiber gap. So, parents are used to hearing like eat your fruits and vegetables, 5210, that type of thing. But talking about the fiber gap levels the playing field. Like I can say, 95% of us are deficient in fiber. And you know where fiber comes from and kind of assess more than just fruits and vegetable, but are they getting legumes? Because that's wonderful. Most of our diverse Hispanic community eats legumes. So I can be like, that's amazing. Beans are one of the healthiest foods on the planet. I'm not a meat hater, I'm a bean butcher. Like they're amazing for you. And so, do you eat whole grains? And then, if they're lacking in like fruits or vegetables, then we talk about accessible, affordable ways to do that. The fiber gap not only expands the conversation, but it also is a way to talk about abundance instead of restriction. So we can have foods that help us feel full. We can listen to our hunger and satiety cues. We can have more of what makes us feel good and it makes our body feel good instead of talking about restrictive language. And especially for families who experience food insecurity, it can be very triggering to talk about portion control. And so, and in our clinic, and you guys may experience this as well, but some cultures and just some families love to feed their kids. I mean, that is like what we do. We want our children to feel fed and happy, and sometimes they reward in that way, right? And so we can talk about abundance again instead of restriction. So it opens the conversation. Also, addressing the fiber gap ties into supporting cultural heritage eating patterns. And just yesterday, I was taking an Uber ride with a guy from the Democratic Republic of Congo. And I'm like, what do you eat regularly here? And he said, well, I don't really eat out much. I cook at home. What do you eat? Oh, I eat like beans and rice, and I just put some vegetables on them. I'm like, that's amazing. That's a cultural heritage eating pattern that we should encourage, right? So, old ways is a really fun way if you want to learn more about this topic. But the data shows that people who eat with cultural heritage eating patterns, they tend to eat a wider variety of fruits and vegetables, more spices, which are literally the most nutrient dense food on the planet. They tend to eat more at home, regardless of income. They tend to have a positive relationship around community and food. They tend to have healthier food preparation um, patterns and have a wider variety of um, ways that they, I guess you could say, sustainable food practices. So, cultural heritage eating patterns are something we can encourage easily when we're talking about fiber because most cultures are healthier than the standard American diet, right? And in lifestyle medicine, we talk about this a lot because there's such an international focus there. So I like to talk to my residents about the idea of equipoise, which I heard a couple years ago at one of the lifestyle medicine conferences. So when somebody says, is this thing healthy? Instead of just directly going for that, asking other questions like, well, with what or instead of what? So if somebody says, is a potato healthy? Well, what do you put on your potato? Like, is it sour cream and butter or is it salsa and black beans? Because those are very different, right? So it encourages deeper thinking about eating patterns. Another idea is instead of what? So, what is it replacing in your diet? So if somebody said is I'm not going to use a brand, but like a processed veggie burger, is that healthy? Well, what is it replacing in your diet? If it's replacing a beef burger, yes. I mean, and especially if if you struggle with adverse lipid profiles, yes, it's healthier. But is it healthier than a real black bean burger that has vegetables in it? No, it's not going to be healthier than that. So these are ways to kind of get families to be thinking a little deeper about their questions about is this healthy or is that healthy? You probably know what I mean um, when I say provide parenting resources. So, have you ever had like a family in clinic and you kind of know what's underlying this is the inability or difficulty setting boundaries from an early age, with the children? And so it's kind of out of control. And the parents saying, well, he only picks this and he won't eat this. And it comes this kind of blaming game that's really difficult. So we find that sometimes the best place to start might be parenting classes, and we have free virtual or in-person parenting classes that are not just around nutrition. It's about teaching a healthy, like authoritative parenting style that we know is associated with better health outcomes, better academic performance, all of that. So, have you heard of the Ellen Satter Division of Responsibility before? You've heard of this? Yeah, I love it. So, this is something we teach our residents to think about when we're hearing this issue of parents having to police their child, and we want the child to be learning their hunger satiety cues, and we want to stop the conflict around this, right? So what this division of responsibility says is that a parent is responsible for the what, when, and where of feeding, so predictable times, healthy options, at home or soccer field or wherever you eat. And the child is responsible for how much they eat and whether they eat it. So they're listening to their hunger and satiety cues. The parent is always providing something that they know the child will like and a variety of other things to encourage that. So we really use this principle a lot, and so does our dietitian. If you haven't heard of the Dr. Young Project, she's a pediatrician that's involved with lifestyle medicine, and she has this incredible nationally recognized program called the Dr. Young Project. It can be purchased for preschools, but there's also a lot of free things that you can access on there if you're interested. And I wanted to share my one of my favorite principles that she teaches. So she says that, and this is what I teach even at a 6-month-old visit. So she teaches that we speak to parents about emerging eaters like we would speak to them about an emerging reader. So you know that reading takes modeling, it takes support. You might take a couple steps forward and then a couple steps backwards. And you would never say, this child can't read. You say they're an emerging reader. And it's the same with eating. So if they have this expectation of it as a process that requires modeling and support and steps forward and steps backwards, that's a nice concept to start teaching from an early age to parents. And even incorporates that idea of toddlers, that neophobia, ways that you can expect normal bumps in the road with eating patterns. So the Dr. Yum project, I meant to highlight where it says Meal-O-Matic, but there's a free app and it's free online, and this is a great way to get kids involved in the clinic. Our patients love this, and it can use whatever you have. So if you have the $5 fruit and veggie box because you have SNAP benefits, you can plug into this. Like, I want to make a soup, or I want to make you know, they have a whole host of different recipes you can make, a bake. Stir fry. So you plug in what you have at home in your pantry or in your freezer or out on your cabinet. So for broth possibilities, protein possibilities, your veggies, and it pops out a recipe, and then it also pops out a video that tells you how to prepare it. So it's like teaching food prep, making it fun, involving the kids. So I just wanted to mention that resource to you. So when we think about community resources for nutrition, like our office is reliant, as yours may be, on cross-sector partnerships in the community. In addition, we have many of them gradually that we've brought into our clinic. So we have WIC, we have PASOS, which is a Hispanic Alliance program to connect our Hispanic families to services. We have OT and PT, nutrition, lactation, all like within our clinic because of the barriers that it takes for our families to go outside of the clinic walls. So for nutrition community resources, I always think of mental health. First of all, addressing like what's underneath our eating patterns, and also the impact of stigma, bias, bullying on children that have obesity. Food navigating, so you probably do a fair amount of that yourself with patients, but we also have a person designated as the food navigator, and she's looking by zip code how to personally help a family where it's not enough just to make sure they have WIC or SNAP benefits. Culinary medicine programs are a great way to do this, and our medical students and faculty who are interested in doing this do learn to prepare the food with that $5 food box that I was talking about, so that you're learning to prepare food on a budget so you can teach your patients that. Community gardens are great places, of course, to encourage the community around learning to grow healthy foods in a pot or in a little plot of land. And then we can't ignore how important the school nutrition system is to us, because our patients probably have 2 meals a day, 5 days a week, at school. So this is a great area for advocacy. And if anybody's interested in that space, every school is required to have a school wellness committee. So ask who's on that school wellness committee. Find out, what they're serving for their meals and how you can incorporate possibly like farm to school opportunities, or water being an option, healthy plant proteins as an option for meals. So there's so much space here for advocacy. For physical activity, you probably know that 1 in every 4 school-age children and adolescents meet the activity guidelines. And those numbers get worse as kids get older, as they have special health care needs, or as they're more impacted by the social drivers of health. We know that for all interventions, including physical activity, if we can have it be family-based, it's going to be more successful. And it's helpful for families to know that accumulated physical activity can be just as impactful as continuous. And so sometimes that's easier to fit in little bits throughout your day. So some strategies around this in clinic. Of course, we all are talking about reduced sedentary time, because any physical activity is better than none. And as you're sitting in your chair after breakfast, if you even do little calf raises with your feet, toes on the floor, a soleus push-up it's called, for hours, you're going to be improving your metabolic health and your blood sugar just by doing that. So any physical activity is better than none. I know you're doing it now, right? I know I was doing it as I was talking. Screen time, I never know where to fit in this discussion, because it fits in with so many pillars. It fits in with sleep, it fits in with physical activity, it fits in with nutrition, because of the truly despicable marketing to children, and especially minority children. So I put it in here just as a reminder that screen time impacts physical activity as well. Do you all ever write fit scripts for physical activity? Because this is a nice thing to know about. It's a SMART goal made quick for physical activity. So it's frequency, intensity, time, and type. And you can do it for play or physical activity. Play or some kind of exercise. And so that's a nice way to be quick in clinic, FITT goal for physical activity. One of our residents did a QI project on teaching that to the faculty and residents. Another of our residents did a QI lifestyle medicine project on promoting preschool play, because when they surveyed everyone, they were familiar with the school age and older recommendations of an hour a day and 3 days a week that build muscle and bone strength, but they weren't familiar with preschoolers needing 3 hours a day, structured and unstructured, and not sedentary for more than 1 hour and less sleeping. And anybody who's had children knows how busy this phase of life is. And I think we're seeing this trend towards, like, with screen time and other, devices like the little children can sit in and play in, that parents just want their child to sit still sometimes, and we can understand that. But normalizing the amount of activity that preschools need for their brain development, for their growth, for their health, is something we can do from an early age. So I mentioned time in nature because I heard this crazy statistic from a book that's about to come out, and he spoke to us at a lifestyle medicine conference, that we spend 93, maybe not you guys, but in general, Americans spend 93% of our time indoors. That is as much time as you would spend indoors in a maximum security prison. And it's thought to take 3 to 6 years off of our life, the way that we're living. And intuitively, living in a place like this, and the research would back it up, that being in nature is good for our physical health and our mental health. So this is something that when I'm giving a fit goal, if there's ever an opportunity to make it to be outdoors, we're going to do it. And we're going to talk about the benefits of being in nature and then layering those two interventions together. Community resources, we try to know our affordable after school programs that have healthy snacks and also have physical activity to engage with. We've created lists with indoor exercise and outdoor exercise activities. So there's some free apps like Go Noodle for little kids, or the Nike app is excellent. It's like Peloton and it's free basically. So for older kids, exergaming is an acceptable alternative for folks that need to be inside, dance or sports, and then active play indoors for little kids, like, pretending like you're an animal walking around the house, that type of thing. We also have this system that we created that's a pediatric support system, dot phrases. So our community health arm of our children's hospital helped us with this. And so we have dot phrases like dot PSS, the county you're from, and then what you need. Like, you need food, you need places to play and be active, you need counseling. And that helps our providers really quickly connect families with places that they can exercise near where they live that are safe. And then physical activity is something I think of, especially in those that are impacted by obesity. Sometimes kids need a boost. They need confidence in being physically active. And we can, code for mobility issues or coordination issues and get them in with physical therapists that can help them feel more confident before they might join a sports team or start playing more at recess. Sleep, for sure, is more than just a good feeling. And we know that sleep is beneficial for all metabolic indicators, hypertension, school performance, like, this, right? Um, Inadequate sleep is associated with increased risk of obesity for all age groups and adolescent depression as well. And there's, good evidence around all of this. We know that it's important. Some of the strategies that we teach our residents in clinic is, this is a free sleep scription. This one happens to be for school age kids. So it reminds them what hours of sleep are recommended. It allows them to track it if they're interested. And then if they aren't meeting the goal, they can choose a sleep hygiene goal underneath there. So they're just little, pads, or you can hook it into your EMR. These are free resources through ACLM. Environmental risk reduction has to do with, when I think of families that live in doubled up housing, which are like the invisible homeless. They're frequently missed on screeners, so you're living crowded into an area. An environmental risk reduction for them or for anybody else could be thinking about something to cover your eyes to keep it dark, earplugs for noise of people kind of coming and going in the house, maybe a darkening shade, maybe even getting medical legal teams involved for housing situations. It could go as far as that. You probably know about CBTI. It's a great free app for teens and adults. And then there's one called Sleep Ninja that's for younger children that's fun. So this can be a good place to start with sleep goals with children. I like to talk about social jet lag. So it's that feeling that I've had the past 2 days, but chronically, of being tired, or maybe your focus or your irritability or something like that. So jet lag, because you're not getting consistent sleep from your weekdays to your weekends. So ways you can work on this is try to make it as consistent as possible. Also, 10 to 15 minutes of natural outdoor sunlight that's unfiltered in the morning. Trying not to take naps on those days, kind of getting your circadian rhythm back in action. I also like to talk to kids about their screen needing a curfew, because they're used to people saying, put your phone away. So I'll be like, I'm not worried about you, but your screen needs a curfew. Your screen needs to go to bed about an hour before you do. And this is not just important for the number of hours they're sleeping, but to get good deep sleep. And deep sleep in adults is also associated with like a 40% reduction in Alzheimer's. Deep sleep is so important because this is the time where the glymphatic system is going to work and like sweeping out these waste products that accumulate during the day, like amyloid and tau, and leaving you truly refreshed, able to focus in school. So it's more important than just the number of hours. Um, Stress, usually I have a case that I'm building this around, but stress, we know, impacts all other domains of lifestyle. When you're stressed, it's harder to like eat healthy, for instance. And all other 5 interventions are powerful for reducing stress. So it kind of works both ways. And 50 to 80% of illness has a stress-related component. Um, the CDC showed that 75% of high school students report at least one adverse childhood event. And the increasing number of adverse childhood events and those that aren't buffered by safe, stable, nurturing relationships and positive childhood experiences, those lead to toxic stress, which end up through that cascade of changes adversely impacting your nervous system, your cardiovascular system, immune system, and endocrine system. And also, this kind of toxic stress creates like an allostatic load that's like dysregulating. So it's this wear and tear on your system where you're not able to emotionally regulate as well, and your body's not able to physically regulate as well. So we can't say enough importance about stress reduction and mental health. So this is that classic kind of adverse childhood experiences pyramid with a few things added on by Leah's Pantry, which is the nationally recognized program in trauma-informed nutrition. And what I like about this is it shows the pyramid starting with adversity at the bottom, of course, heading up to the risk factors for the leading causes of death in adults. And along the way, you see that red line, that mechanism that involves adoption of health risk behaviors. And when you think about this through a trauma informed lens, there are many families out there that what they need to do, they need help understanding and reflecting on what's underneath the lifestyle patterns that they're struggling with, because that might be the key to unlocking change. And then when we're talking about lifestyles, rather than just being a SMART goal to meet or a checkbox, it's an invitation to true like healing and connection around these issues. So I like to think of this as like the biology of chronic disease and poverty, or the biology of obesity and poverty, which is a physiologic response to a pathologic environment. Stress management strategies and resource. We would all use our mental health services. We love our school-based mental health because the kids are right there to get the help that they need. The free apps in this space are Mind Shift for older kids, and Breathe, Think, Do with Sesame is for little kids and for parents to help children with resilience and coping skills. ACLM has some free like 0 to 5-year-old toolkits and an adolescent mental health toolkit that's great. And then social prescribing is something I just want to talk about because it relates to this pillar and the next pillar of social connection. So social prescribing is like an intentional giving a prescription for spending time with other people, because that is so important, is that social connection. This The early relational health framework that you're probably all familiar with talks about the biologic necessity of safe, stable, nurturing relationships and positive childhood experiences to buffer or reduce the toxic stress that kids experience, right? So even something like I feel sure you do reach out and read in your clinic, right? Or something like that, giving out books in the clinics. And so just that is prescribing social connection and stress management, because you're spending time with an adult in your family, whether you are chewing the book, flipping 4 pages at a time, or wiggling all around, you are spending time in somebody's arm that cares about you and having a positive childhood experience and hopefully a safe and stable, nurturing relationship. Got advancing. Oh, there, sorry. After 10 tries, it advanced to the next slide. I'm sorry for those online. Thanks for your patience with that. So, social connection overall is the single most important predictor of happiness and longevity. And the 2023 Surgeon General focused on this both for the individual and the community. And the report at that time was called Our Epidemic of Loneliness and Isolation. So, we know that being socially disconnected has the mortality impact of 15 cigarettes a day. That's more than obesity and physical inactivity combined. This is really important. In teens, social isolation increases the risk of inflammation by the same magnitude of physical activity. I was visiting my son in Spain last year, and it struck me that everywhere we went, it was built around community. And it's not like that here. People are living in their own silos, going here or there, but everything there is centered around like public squares and ways to interact and lots of places to eat together. Um, and we need to advocate for more of this in our own setting. So, of course, we need to ask about social connection, which you'll probably do on your heads exam, kind of get to that. Are you feeling connected with other people or your family? Um, and referring to counseling as needed for folks either having trouble connecting with others or perhaps just the impact of not being able to connect with other people well. Social prescribing, as we talked about, and a nice way to do it in this space is around family meal times. So 20 years of evidence shows all the benefits of family mealtime, which you will thank me for not reading that, but it's amazing. And the Harvard, I think it's the Pediatric Psychiatry Department at Harvard, they started this family dinner project. It has a lot of similar resources for individual families like healthychildren.org has. So like conversations around a mealtime, how do you implement family mealtime if you haven't been doing that? And it's a dose response like for health benefits, how often you have family meal times. But the other thing I like about the Family Dinner Project is they have ways, it's like free and boxed up for you. If you want to start having family dinners, like family dinners with community members, they do it even at a food pantry so people can learn about what the food pantry provides. And it's an opportunity for social connection and discussion with healthcare providers about nutrition. I just heard her speak recently at our national member interest group, and it's something that we are thinking about doing at our own food bank. It looks very easy the way they set it up. So, avoiding risky substances, this is probably the one we all learn the most about in medical school and residency. And the main thing I wanted to point out is just like all the other pillars, there are disparities in screening and access for patients with the social who are impacted by the social determinants of health, including racial and ethnic minority groups. And lifestyle is truly underutilized still in the substance use space. Lifestyle interventions have shown to influence epigenetic and neuroplastic changes in the brains of people being treated for substance use disorder. And so it's growing in that field, but primary care providers in pediatrics as well as family practice and internal medicine are at like a critical juncture with patients to be able to start working on those things, even if they are referring outside for the expertise as well around substance use. So this is like 2 or 3 slides, kind of to tie it together about the synergy of these lifestyle interventions. So this is Rosa. She's a 15-year-old girl. She's here for her well check. Her last checkup was 3 years ago, and she's now in the care of her grandmother for the past 2 years. And her grandmother's primary concern is her mental health. Her BMI has increased from the 75th percentile to now 120th of the 95th, and they're assessed as pre-contemplative stage of change regarding the obesity because their main concern is her mental health. Her PHQ-9 is moderately elevated. You notice this flat affect. You see acanthosis nigricans. She has an elevated blood pressure and these recently healed linear scars on her forearms. So visits like this when there are so many competing priorities for your 15 minutes of time and we need to meet patients where they are. And for this patient, meeting them where they are would mean starting with mental health and using our clinical practice guidelines for primary care and adolescent depression. We would be talking about the options for medications and counseling. And even if the family chooses both of those, which would be great, we have to recognize it's going to take time to work. And I found that very frustrating as a provider, like having to say your medication will, maybe start taking effect in about 4 weeks and we're going to have to adjust it. And I'm not sure how long it's going to take to get in with a counselor. And then we're hoping they like that first counselor, right? And so lifestyle medicine gives you this therapeutic options, like six of them, seven of them if you include nature, but therapeutic options of things you can offer to the family that day. Actually, that AAP clinical practice guideline has one line about how important lifestyle is with a ton of references, but there's no place that says how to do that. And so for me, for everything, what I've found is that the AAP, those guidelines are my what, but lifestyle medicine has really provided the how to and how to do that in conjunction with other people across the lifespan. So there was a 2022 review article in the Harvard Review of Psychiatry looking at adolescent depression and just mental health in general with the lifestyle pillars. And they found that lifestyle can be used as part of a comprehensive plan that includes medication and includes counseling. It can be used independently for those who would benefit from those things but aren't ready for them or have barriers to obtaining those, and that it can be used independently for patients with mild to moderate depression. And all of the lifestyle pillars have solid evidence, you can read it in this article, for adolescent depression. Um, so before leaving this slide, what I would say with a patient is, talk about the clinical practice guidelines and kind of make the recommendations. And then I will say, if you're interested, I could talk to you about a lifestyle habit or two that you could start using today or this week if you're interested to address your depression. And I've never had anybody say no because it's quite empowering to think you could do something that week. And I'll give an option based on what I've heard during the visit. Like, would you want to talk about sleep or physical activity? Social connection, physical activity. And say they choose physical activity. Then I'm going to try to layer it with the other lifestyle interventions. So I'm going to help them choose what would be fun and accessible for them for physical activity and try to pair it with another person for social connection and try to be outside for the benefits of nature. So then you've got three overlapping evidence-based principles that they can start on as they're waiting for their counseling, as they're waiting for their medication. So for the last few minutes, I just wanted to share a little bit of some of the work that we've done in Greenville and in South Carolina. In our clinic, in our program, we used to have a multidisciplinary pediatric obesity treatment center that was around, 2013, something like that. And it closed around 2019 for a variety of reasons, including people not being assessed for readiness to change before they were sent there. And so they closed, and then COVID hit, increasing the rates of obesity. And we were just overwhelmed with the amount of obesity we were addressing in the clinic, and we didn't have a consistent approach. So around 2019, we kind of put our heads together. I was certified in lifestyle medicine. The medical director of our clinic loved it, and she got certified in lifestyle medicine. And then we created a team of people called our task force to start working on this. And what we created was a plan around lifestyle medicine that improves the quality and consistency of the care. I will admit, before we did this, it wouldn't be unusual to see a chart that said the child had obesity. Maybe they weren't ready to change, and we'll see you in a year. And that's not acceptable. So even for families that are not ready now, we've trained our faculty, our residents to use motivational interviewing to find a reason to see them at least every 3 months, even if it's around asthma or acne or something else like that, to give us an opportunity to continue that motivational interviewing and maybe use lifestyle pillars through the back door, like addressing depression is also addressing metabolic issues, right? So you can address it through the back door by what's important to the patient. Constipation, you can tie in lifestyle medicine for that. So this optimizes readiness to change. So those who are ready for change and have obesity, we can offer to them a more intensive program. So it's like a modified health behavior lifestyle treatment program where they can meet with our dietitian and she covers the nutrition aspects, and the provider covers the other 5 pillars of lifestyle medicine to make sure we have this comprehensive approach. And it all starts with like an intake visit with screeners that include the social drivers of health. So we're using all 6 pillars. So we had this in place for several years before the AAP clinical practice guidelines came out. And those, were fantastic, but they still didn't tell us how to do that. And so we ended up being asked to do a lot of training around our state and present this at a national level because it was a way that was using all the evidence base we know in pediatrics and doing it in the clinical setting in a way that wasn't taking any more time. And we were just training people along the way. So we tried to, embrace a weight neutral approach, do no harm, think about our terminology, recognize our own stigma and the stigma and bias that patients, experience in the community. We of course want to screen for disordered eating and the parents and the children, but it's this whole family, whole child approach. And we reframe around abundance instead of restriction, reframe around habits being far more important than the numbers. So if you are practicing healthy habits, your health outcomes are going to be better, whether your BMI changes or not. So we try not to talk about we try to talk about numbers as little as possible or not at all. And then this is a marathon and not a sprint. And we're there with you for this. And this is another free resource around this through lifestyle medicine. So through part of this work, we ended up creating a South Carolina Healthy Lifestyle Subcommittee, and we surveyed all of our pediatricians in the state and asking what are your barriers around caring for patients with chronic disease and obesity. And as a result of that survey, we started this quarterly learning collaborative, and it's actually been since 2023. We've reached every county in South Carolina. It's interprofessional, so it's not just doctors, so we can learn from each other. And the way we organize it is you have like 20 minutes of didactic on a topic like MASLD or something like that. And then you have time for discussion and sharing. And we always highlight a community partner or a cross-sector partnership that everybody should know about in our state so that they can enhance the work they're doing and connect them with their community. So that's been a fun initiative through lifestyle medicine. We also have a lot of need and interest in our community, especially because our med students are very well trained in that. I think the community of Greenville hears about lifestyle medicine. We recently decided to embed it at the community health arm of our children's hospital so that we would think of lifestyle medicine no matter what initiatives we were talking about. Is there a role for lifestyle medicine in this? And we have lots of community partnerships that we use. I'm going to show my last 2 slides are the 2 most recent things we've worked on in our community. So we received a small grant from NASFGAN, like the world's worst professional acronym for the Pediatric GI Association. But we very much appreciated their grant, and we learned how to spell it. So we wanted to address fatty liver disease in our diverse Hispanic community. So this is one of our medical students, and she's doing a tour with members of our Hispanic Alliance, and they're talking about how to eat healthy on a budget in a culturally preferable way at this store that many of our patients shop at. And at the end, it has QR codes and information on any kind of food resource we know about or programs that families might qualify, so it's all in one place. And we're excited. I think it's 2 weeks from now, we're doing a big kickoff. It was going to be in person, but because of safety concerns and the community that we're serving, we decided to make it virtual, and then they get groceries delivered to their house for participating and letting us know what they think of the video. And then the last one, this program, there is a preschool, Dr. Yum program for the community. There's Lively for teenagers, and there wasn't one for school-age children. So we got a couple of fantastic medical students who were teachers in their former life, and we created these 30-minute interactive lessons around the lifestyle pillar meant to be delivered over 6 weeks. And we just finished our first full cohort at an after-school Hispanic program in our community. The YMCA wants us to incorporate it. We just have to make sure there's enough medical students to staff it, because it's the medical students who learn the curriculum because they know adult lifestyle medicine, but they learn the pediatric aspect, and then they teach it after learning it. And so we're kind of tracking what the teachers think of it and what the recipients think of it. And it's for families and children. The medical student who helped me with this has very strong connections to Utah and to the medical community around here. So she really wanted to come and be my assistant coming out here, my lifestyle medicine assistant, so she could ski or play up in the mountains. So kind of going back to that quote I mentioned earlier that talks about the power of hope through action, I just hope that there's something in this that brings you like inspiration, ideas, maybe tools that enhances what you're already doing. And I'm happy to serve as a resource if anybody wants to know more about lifestyle medicine as a specialty, please reach out. So thanks for your attention and thanks for having me today.
Thank you so much for teaching us. If there are any questions, you can come up afterward, kind of talk to Dr. Brackbill. I'm ready to prescribe something that's not a medicine now. Like I feel like I can prescribe one of the lifestyle things and meet a patient where they're at. And you give me a lot of the language to do it as well and so many tools. So I appreciate you. And the code is 52528. Thanks, everyone.
Thank you. And I'll stay up here for a while and I'm accessible afterwards. So thanks.